Long before the abrupt detour of having to deal with COVID-19, many leading hospitals and health systems around the nation were hard at work on redesigning their fundamental delivery systems for healthcare, identifying and implementing long-term changes to bring improved outcomes at lower cost. Now they're eager to finish the job. Welcome to Advancing Health, a podcast from the American Hospital Association. I'm Tom Hedderly, senior writer with AHA. The University of Tennessee Medical Center at Knoxville kick-started its own care redesign process in 2008. The goal of the ongoing work is to transform its delivery system to disease-specific, evidence-based, patient-centric plans that span entire episodes of care. So what does that look like, and what does it take to get there? In this podcast, Julia Resnick, Senior Program Manager for AHA's The Value Initiative, explores those questions and others with the University of Tennessee Medical Center's CEO and Chief Quality Officer.
Joining me today from the University of Tennessee Medical Center are Joe Landsman, President and CEO, and Dr. James Shamiyeh, Senior Vice President and Chief Quality Officer. Thank you both so much for being here. Let's jump right in and start with some background on your clinical integration and standardization journey. What was the problem that you observed, and why is standardization the answer?
Julia, when we began this journey and really became laser focused on our clinical integration and standardization journey, it really began with the conversations that were surrounding the development of the Affordable Care Act. And at the end of it, we looked at the fact that there was a number of different issues that we faced within our industry. And while the Affordable Care Act was taking steps to address some of those issues, we felt that as a provider of healthcare services, we needed to embrace the issues that we had and try and affect change in the areas that we had some influence over. So it really centered around a couple of things, and the first one being, depending on what you read, much of the literature will tell you that in the United States, it takes about 17 years to adopt evidence-based medicine. The second issue that we had is that when we looked at high-performing organizations within other industries, it was pretty clear to us that one of the commonalities was using a concept of standardization that did drive quality and actually improved service for their customers. And that's something that we as healthcare providers have not embraced. The third component of this was that we, as a result of that lack of standardization, saw variation in just about everything that we did. We saw variation in the outcomes of our patients. We saw variation in the cost of providing the care to those patients. We saw variation in the experience that those patients had when receiving care on our campus. And that variation also translated into variation in experiences and efficiencies for our team and our physicians. And so we felt very strongly that those were things that we could influence. At the end of the day, improve the product we deliver. And so we set a vision of three corporate priorities. One is high-quality care delivered safely. And when I talk about quality and safety, I'm talking about not only for the patient, but also for those that are involved in delivering the care. We do not want our team members or our physicians hurt in the course of treatment, and obviously we want our patients to receive high-quality, safe care as well. The second component is for everyone involved in that process, patients and caregivers and physicians, to have a good experience in that process. And then also to provide all of that as efficiently and effectively as we could. So that was the beginnings of our journey towards standardization and clinical integration.
And if I could just add to that, we recognized early in this journey, as everyone who's listening I'm sure can attest to, that healthcare delivery has historically in this country been somewhat fractured. It's delivered in silos, and that those silos or those different care areas don't communicate well with each other. So we were interested in trying to streamline that care and deliver it essentially seamlessly across the continuum early on. And it became very clear that in order to be able to do that, you had to have some mechanism towards standardization, acknowledging that healthcare is not in any way a cookbook type process. And so every situation has its kind of uniqueness, but still, if you're going to be able to go down a clinical integration path, you have to have some mechanism to do things in a standardized manner.
So that's great, and I would love to hear more about that path and what that journey to standardization really looks like in practice at UTMC.
That's a really interesting question, and it has been a very long journey. We started this really as the Affordable Care Act was being formulated, and that started in around the 2008-2009 timeframe. So let me first describe what clinical integration means to us, and then I'll talk to you about the standardization component of clinical integration. So for us, clinical integration is a commitment to providing the care throughout an episode of care that is based on an agreed-upon, evidence-based, patient-centric plan of care. That plan of care will span the entire episode. So if the vision is if the episode begins in the emergency room or a physician's office and ends after a hospitalization and maybe after a rehabilitation stay or a SNF stay, skilled nursing facility stay, that pathway or care plan covers the entire episode. The other part of clinical integration ties to having surrounding that care plan approach to care chronic illness management programs that deal with the chronic illnesses that our patient population has, and in East Tennessee we have a prevalence of chronic illnesses, and we believe that those need to be centralized and staffed with passionate, knowledgeable experts on that chronic illness that can engage with the patient either face-to-face or electronically to help the patients understand their chronic illness and help manage their chronic illness. The third component of clinical integration for us, and particularly in Tennessee, given the high utilization of pharmaceuticals, is a medication management plan that, again, brings all of the prescribing providers together to look at the best medication plan for that patient, and then the primary care physician owns that conversation with the patient. So let's talk a little bit about the plan of care. And we began with the inpatient world because that's what we had control over as a hospital system, health system, primarily with a large academic medical center as its underpinning. So the hospital plans of care, or we call them care paths, are built using lean methodology. We first look at the workflow for our clinical team, including our physicians. We then look at a value stream map from the patient's perspective, trying to eliminate all non-value-added steps in that process to really make it an efficient process for the patient. Then we go to the evidence, we build the pathway, then we implement the pathway and integrate it into our EMR system. And the people in the room that are building the pathway are representatives of every aspect of clinicians that care for that patient. So we have physicians, we have, and not just representing one specialty, but many specialties, including primary care. We have pharmacists and respiratory therapists, and obviously nursing. Sometimes we have pastoral care there because they represent a resource for patients that are facing end-of-life issues. So those are the folks that actually do the workflow redesign, look at the value stream mapping process from the patient's perspective, go to the evidence, find the evidence, and then build the pathway according to what the evidence says and those redesigned processes look like. They get implemented into the EMR, and then we measure the effectiveness of those pathways 5 ways. Number 1, are we complying with the pathway? Number 2, mortality. Number 3, complications. Number 4, readmissions. And number 5, length of stay. And those metrics are reported up through our board of directors through our PI process.
So just to add on that point, we've been very fortunate in building that process to have a very high level of physician engagement and actually engagement from many of our team members. And so, for example, if we're developing a pathway for sepsis, we would have in that same room medical and surgical intensivists, we'd have hospitalists, pharmacists, information technology, and even because of the importance of timely lab draws, we'd have the lab. And the way that works is part of that discussion will be about the latest in evidence-based care and may even end up being a very vigorous back and forth discussion about what is the evidence that should land in the pathway. But then some of this ends up being about workflow as well. And then the ultimate product should merge those two issues where we have a mechanism that is standard to deliver the best evidence-based care, but then also something that helps the providers and the physicians deliver that care as efficiently as possible. The other piece of that is that if you have people involved with the creation from beginning to end, then the level of buy-in in the implementation has been much easier. And so we have this model or this process that we go through with the creation of pathways, and that in and of itself had to be created and refined so that the pathways themselves could be created essentially over a few years. We have the majority of our patients covered with these care paths.
So the care plans, the way we've designed these is that, once we have built the plan of care or the care path, they get reevaluated based on current evidence no less than every 3 years. So we're always staying current on the most current evidence-based medicine. Now, obviously, if there is a issue that comes up that says stop doing this because you might cause harm, that gets addressed immediately. But on a routine schedule, no less than every 3 years, the pathways get updated based on the evidence. Where we are today is about 95% of our inpatients are on disease-specific pathways. And these are not physician-specific order sets. They're disease-based, so every patient that comes in with that diagnosis gets treated according to that pathway. The pathways have now extended into post-acute care, into the post-acute care arena, so it's our rehab facilities, our long-term acute care facilities, our psychiatric facilities, our home health facilities, our nursing homes. And we've looked and really learned that there really weren't that many pathways that had to go extend into the post-acute care arena, but we have now contracted with post-acute care providers. Part of that agreement is we'll send them the patients according, within the regulatory requirements of patient choice, but they are required to follow our pathways when they have one of our patients. And we have a set of metrics that measure their success rate, including returns to the emergency room, readmissions, and length of stay in their own facilities, because that's where a lot of the cost resides in the healthcare delivery system, is in post-acute care. And we have some, in both the inpatient arena and the post-acute care arena, we have tremendous outcomes in terms of improving quality and reducing cost, and we can quote some of those here in a little bit. The pathways have also started to be, and this is the robust and comprehensive and complicated part of the pathway design and implementation, and that is moving them into the physician practices. And so far we've focused on the primary care practices and have really focused on things like HEDIS measures, making sure that we've included in the pathway and in their practices those metrics and that standardization for the patients that all should be cared for, and certain things happening for certain populations. The chronic illness management programs are in place. We have, I think, 3 of 5 built and implemented, and the medication management program that I spoke of is also being deployed. We're moving from a pilot project to a full deployment that as a huge benefit to our patients in being able to make sure they understand their medication plan and be able to comply with that plan. And then we've also worked with the pharmaceutical companies for those patients that wouldn't be able to afford all of their copays and deductibles to be able to secure the meds that they need without having to prioritize those meds and make sure that they were able to stick with the plan.
Wow. It certainly sounds like your system has gone through a lot of changes over the past decade. What did it take to change the practices and behaviors to get to this point of standardization?
Well, it was kind of interesting. I think part of it was very deliberate and part of it was being a little fortunate in our timing. So let's talk about the timing first. We developed this strategy, and it has matured over time. We didn't quite start with this robust vision, but it has matured as we've implemented over the last really 12 years. But we started with a burning platform being the uncertainty that was surrounding what the Affordable Care Act was going to look like. And then we have a very strong partnership relationship with our medical staff, which really is the underpinning of being able to do something like this. You've got to have an alignment with your medical staff and good relationships with your medical staff where, they will support the initiatives of the medical center as the medical center will support the initiatives of the physicians. And so that's just been a long-standing culture on this campus, which really was the foundation for us to be able to move down this clinical integration road.
That's great. And how has the work evolved over time?
I'm going to let Dr. Shamiyeh take that one, and I might have some other comments.
So one notable thing about this type of work is that you're very much, I wouldn't say limited, but this lives in the electronic health record. And so as the capabilities of your platform change over time, the ability of what you can do from an information technology perspective changes and evolves. And so one interesting challenge with this kind of work is sometimes your vision may be ahead of your technology. But that being said, you have to be able to adapt because technology is constantly changing, and so there may be different ways to do something now than there were 5 years ago. And so one of the ways that this has evolved has been continually looking back not at the content of what we're delivering, which we do. We look at that from an evidence-based medicine perspective, but also looking at how the product is delivered to the user. And so the other thing that we've had to do is as the whole standardization process has moved through the continuum from inpatient, then post-acute care, and now the challenge in the outpatient setting, each one of those areas presents its own unique issues from an IT perspective. And actually what that can do is you can learn something in one venue that you can then turn around and apply that will improve what you're delivering to the user in another venue. So the more you're able, the more this expands, and the more different areas you're working on standardization and working on implementing for what we've done, these care pathways, it actually makes the entire product better, because the better you are at integrating, then the smarter the process is all the way around.
And so I would add, to your question, a good example of the evolution of these care plans. This year we are actually, and we've always had good, robust patient education processes and materials, but we have an electronic system much like a hotel system where our patients can order movies online, but they can also, and more importantly, view their patient education material online on demand. And what we're now doing is taking the key milestones in the pathways and incorporating those and embedding those into the patient education material so that the patients have a better understanding of what they should expect, what should be happening, and if it's not, they become another line of defense to make sure that they get the care that is pursuant to that pathway. I'll give you a real simple example. If a patient's in the room 2 hours post a knee replacement and somebody's not in there ambulating them, and the patient reads watches their education material online and realizes I should be up and ambulating, And if it hasn't happened, they can start asking. So they've become engaged into their care process, which we know will result in better outcomes for that patient. It's also speaking to consumerism, the entry of consumerism into our industry for the first time in a meaningful way, and helping engage the patient in the care process as well.
That is so great to hear about. So, Joe, you had mentioned earlier that you have a lot of data, and I'm interested in what impact you've seen as a result of all of this work. That's in terms of clinical outcomes, cost, and the patient experience, all of which you really outlined as your three main tenets early on.
Let's talk about the four ways we're measuring the effectiveness of the pathway: our mortality, complications, readmissions, and length of stay. And as we've implemented these pathways and deployed the pathways throughout the care continuum, we've seen all four of those metrics improve. We have also data on how our costs compare to other providers in our market, and I can tell you over that period of time, we have gone from being the highest cost provider on a per member per month basis to being the lowest cost provider on a per member per month basis. We have amassed a number of different national awards, just recognizing the work in and of themselves. I'm not a big proponent or place a lot of meaning in these awards, but when you start to accumulate them at the level that we have, it does speak to the fact that you're moving in the right direction. We have data that says that we have reduced the number of post-acute care referrals dramatically. I think the number is over 30%, which saves money. And we have reduced the length of stay in those post-acute care providers. We've also reduced the readmissions to our facility and the returns to the emergency room. So the data is showing that this journey is being effective. You know, we do have a clinically integrated network structure of a company that's a wholly owned subsidiary of the hospital, but actually a partnership with our large IPA, and we are performing very well in terms of the incentive components of our contract that are housed in that company. And so we're also seeing financial benefit of meeting our targets and meeting our metrics.
James, anything you want to add there?
The only additional comment would be that we have the ability to drill down at a more granular level with our pathways to look at very specific pathways and specific outcomes. So, for example, heart failure, COPD, sepsis, and our post-procedural states, acute myocardial infarction, we monitor those each independently, and then everything rolls up at an organizational level. And so we have basically many performance improvement committees that may be looking at one very specific issue and its pathway. And the owner of that pathway would generally be a member of that performance improvement committee. So a perfect example would be acute myocardial infarction, where they're looking at outcomes, they're looking at processes, and then ultimately there's a lot of those things going on across the organization, a lot of those committees with pathway owners who are accountable for the content in those pathways, and then that all rolls up to the high-level organization outcome. And so we monitor, and we've seen improvement not just in the high-level overall hospital mortality, but we've seen improvement in very specific disease pathways. And for that matter, it helps us identify opportunities. And so we know where to put our attention so that we can continue, because this is obviously a continual process, and we view performance improvement in the context of pathways and clinical integration as an ongoing process. And so we have a good mechanism in place, and this whole journey has helped us put a very good mechanism in place so that we have infrastructure so that performance improvement comes naturally to us. We know how to go about it.
So I imagine that we have listeners out there who will be thinking, wow, this is amazing. How do I implement this in my hospital? So what lessons have you learned over the past years that you could share with other hospital leaders who may be on a clinical integration journey?
I'll speak to that, and then Dr. Shamiyeh may want to add some comments, but I think the fact that we have had a culture of alignment with our medical staff for a long, long time, the importance of that was highlighted in this journey, in our transformation. I think the really focusing on the product that we deliver has been a journey for us and an evolution where we really do think about the services we deliver and the quality and safety and efficiency and the experience of that process. It's pretty clear that we're looking at the outcomes, and when the outcome varies from what we expect, we really drill down into it to figure out what was going on and address those, and many times that causes or requires an alteration in our care plan. We have also learned that making sure that our partners understand the journey that we are going on, including our medical staff. But more importantly, we've learned that we really do need to be a high-value proposition for our patients, our employers, and our payers. And so making sure that they understand the journey and the vision of our organization has been critically important as well. And, we also have learned that sometimes, what we do doesn't exactly work the way that we expect it to, and we've learned to be nimble and not get stuck in this is the way we want to do it without rethinking that and having a culture of continuous improvement. And I think Dr. Shamiyeh talked to that earlier.
So some additional points of lessons learned, sometimes difficult lessons learned, but I'll go through just a few. At a high level, I think it's key that your leaders in the various areas, if you're going to pursue clinical integration, then you want to make sure your inpatient clinical leaders, your post-acute care clinical leaders, and your outpatient leaders are in the same room together to discuss issues. Because if the clinical leadership is not behaving in an integrated way, then you can't expect the delivery product to be integrated. A second lesson, or another lesson I would mention, is that the outpatient space, as Joe already mentioned, is very, very complicated. And so, for example, a single patient who's at risk for a heart failure readmission could get a phone call from a case manager from our clinically integrated network. They could get a phone call from their primary care office, a phone call from our heart failure clinic, and possibly even a phone call from a case manager working for their insurance company. And that can be overwhelming for the patient. So from the patient perspective, trying to coordinate all this work so it's not totally confusing can be a real challenge. And then I think the final lesson that I would mention is that you really want to take stock of what the landscape of your information technology and your EHR, what it is across whoever you're hoping to influence. Because if everybody's on the same platform and that platform communicates seamlessly, then the level of challenge that you're undertaking is substantially less than if you've got different systems that may or may not communicate. It's not that you cannot pursue standardization or that you cannot pursue clinical integration. You can, but you have to have a different approach depending on what is basically the IT architecture that you're trying to build everything on.
Mm-hmm. So I'm sure that you're not done with this work, so what's next for UTMC?
Well, as I said, and it has been a journey, and we are not finished. The work we're doing this year is to convert, at least on the inpatient side, the pathways to patient education integration, continuing to move the pathways and expand those into the physician practices, and with a focus on primary care initially, continues. And then the continuous learning of this journey and the outcomes that it drives, and how to improve those outcomes, is going to go on for a long time. We learn a lot as we look at the data that's driven by the performance of this vision.
Great. Well, that's all I have on my list. Is there anything else you think it's important for us to know?
I don't think so.
No, I think we covered our journey.
All right. I thought so, too. I just wanted to confirm. So thank you both so much.
If there's anything we can do to help you, just let us know.
Appreciate that so much. So thank you both, and have a great afternoon.